everybody. Welcome back to another episode of our beloved podcast, the Core Consults RX. And we're coming at you with another accredited episode. I feel like we say that pretty much every time. I promise we'll start bringing back some cases and some other, drug updates and some other shorter episodes too.
Someday.
Just, keep talking about it. We just got to make it happen. But doing another accredited episode, this is another topic that we've covered in the past. However, as far as the continuing education credit goes, they have an expiration date, which is now passed. So figured we'd update this one again and, make sure that you can still receive continuing ed credit for it. Thanks to our friends over at freece.com. And, you guys know the drill by this point, but if you're a member of Freece and have unlimited membership, you can get access to all of our episodes that are accredited. And at some point during this episode, we'll give you a password that will allow you to go on freece.com's website and put in access is a better way of putting that. Access the post-activity quiz. 10 multiple choice questions. You get those, or get a high percentage of those, and you'll get your 1 hour of continuing education credit for pharmacists and nurses. And if you're not a member, obviously, encourage you to check out their content. We got a lot of great stuff on there as far as our podcast episodes go. They have all kinds of different monographs and live events. In fact, Cole and I are doing a live event with them on diabetes management in a couple days. So it's Wednesday, January 29th.
That's right.
And so for those of you who are interested in seeing that, it's going to be live. And
8 o'clock Eastern.
So we'll be 8 o'clock Eastern. We'll be doing that, and then they have all kinds of other live things, panel discussions and whatnot planned for this year. So definitely lots of opportunities for learning, and encourage you to check them out. Always a pleasure to continue to work with them.
Yep.
So did I even say what we're talking about tonight, or did I just say we were talking about a topic?
It would be classic not to have said what we talked about.
Yeah. Just start the episode, no intro. Hopefully they read the title of the episode, but rheumatoid arthritis. We're going to be kind of doing an overview of the different medications involved, the DMARDs and biologics and whatnot. And then at the end, we'll kind of summarize them into an algorithm, if you will. And so obviously some of these meds are pretty complex, and so we won't be going super deep into any one particular area, but we'll try to make sure we cover the majority of commonly used medications.
Well, the good thing is there's some overlap with some of the other topics we've done, so if you hear about it enough times, it won't be complex to you. You'll remember these strange brand and generic names.
It's also really convenient for us too, so that we can
talk about the same thing.
Yeah. It's really saves, really big time saver.
But they have different places in therapy for each thing. So
they do. Yeah.
So we'll start off
just not really a time saver. I just said that.
Right. That's true. We pretty much.
I like how you come in and try to save it with it's pretty hard.
We spend about the same amount of time prepping, no matter what the episode is. So it doesn't. It doesn't matter.
Yeah.
So we'll start off just talking about what it is, because there's various types of arthritis. We're talking about rheumatoid arthritis, which is a chronic progressive autoimmune disorder that primarily affects the joints, but can have other manifestations, as we'll see. There's a complex interaction between genes, hereditary factors, and the environment that leads to a breakdown of immune tolerance and leads to synovial inflammation and pain and stiffness and all that. Clearly, we've seen that an individual's genome plays a role in terms of susceptibility and how severe somebody's rheumatoid arthritis is going to be. There are now over 100 different gene polymorphisms that are associated with RA, so there's clearly a link there.
And, there's certain targets that we've kind of really focused on over the last, 10 years or so when it comes to our biologics and whatnot. So some inflammatory mediators and in things like TNF alpha, interleukin 6, interleukin 17, interleukin 1. So you'll see some of these when we talk about mechanism of actions, particularly with the biologics, you'll kind of see a lot of these targets, and how they're inhibited and whatnot. And as far as signs and symptoms go with RA, obviously pain and stiffness is often associated with it. The stiffness tends to be very noticeable in the mornings. It does typically involve joints that are in the hands, wrists, feet, and there may also be some tenderness, warmth, swelling, also associated with the affected joint. And there does tend to be a symmetrical distribution, which is a little bit different from something like osteoarthritis. I mentioned the morning, stiffness because there tends to be like a prolonged morning stiffness, which and we'll compare and contrast here in just a minute as far as like osteoarthritis versus rheumatoid arthritis. But another like hallmark symptom associated with rheumatoid is persistent fatigue. That's often a complaint that patients will have, and despite getting adequate sleep and whatnot, they're still very tired during the day and whatnot, or tired after only being up for a few hours. It can also be associated with things like weak muscles, and if it's left, sort of untreated or, kind of in severe cases, you can actually develop these rheumatoid nodules, and that can affect not just the joints, but other, organs and things like that as well.
Right. In terms of who's at risk for developing it, the most common ages to start seeing symptoms of rheumatoid arthritis are between 25 years and 50 years. But elderly individuals can also develop it. It's more common in men than women, substantially. A 3 to 1.
Vice versa.
Yes, more common in women than men, substantially more. A 3 to 1 ratio. If patients have a family history of it, we mentioned the genetic factors, so that's going to increase risk. Smoking seems to be associated with an increased risk, as well as coffee drinking, interestingly, which I picked up in the last year and a half. So.
I'm not buying that one.
I don't know about that.
That seems like fake news.
You could associate anything with coffee drinking. Anything. Yeah. Literally anything. So I don't really get that.
I associate longevity with it, so...
I thought you didn't drink coffee. You drink caffeine.
No, I drink some. I don't drink coffee like on a daily basis, but I have admittedly been going, which I don't even know if this counts, but I have been going to Starbucks more frequently than I once did, so hopefully I'm not starting another bad habit. But
what's your Starbucks order?
Usually just like a double or triple shot over ice.
Double or triple shot.
Listen, the thing is I like to build a strong tolerance. It's basically prophylactic, against AFib is what I like to think of it as. I don't have any data to back that up. It's probably it's pretty much probably not true, but that's what I tell myself. It's like I'm making sure that my heart is able to tolerate a heavy load.
See, here's my problem is I'm a relatively new coffee drinker, and I didn't understand portion size for coffee. So, I got a coffee mug and figured I should just fill up the mug, and I've got 1 cup of coffee. But of course, depending on the size of the mug, and most oftentimes, 1 mug can hold 2 to 3 cups or more of coffee. I didn't realize this, and so I was getting like amped when I first started drinking coffee, and I'm like, man, I'm so productive for these like 3 or 4 hours during the day that I'm really sleepy after lunch. But those 3 or 4 hours are great.
That's when you grab that same mug and you fill her up again.
Back up. But then I started using a Keurig for whatever reason. I think I was at work or something like that. And so you choose like the 1 cup option, and then it fills up my mug like a quarter of the way. And I'm like, huh.
How disappointing is that?
Is that what it's supposed to be? So,
no.
Yeah.
Serving sizes, I mean, I don't know. With coffee, come on.
Yeah.
Can you really have too much? Yeah, probably. All right. But anyways, let's go through some of the labs that may be involved with the initial workup.
Let's do it.
The rheumatoid factor is one that you'll often see, sometimes a part of an assay. Basically, the rheumatoid factor test is showing the prevalence of, or presence, I should say, of rheumatoid factor antibody in the blood. It's not completely indicative of RA, and in fact, only about 70% of patients with RA will test positive for that antibody. But sometimes you'll see that drawn as part of the overall workup. Anti-nuclear antibody or ANA assays are oftentimes drawn in any kind of rheumatoid condition, and they'll have like a reflex associated with them. So if that's positive, then they'll run a gambit of other autoantibodies and whatnot. Erythrocyte sedimentation rate, which is basically showing the presence of inflammation in the body and activity of an inflammatory disease. There's things like anti-citrullonated peptide antibody or ACPA, which is, again, looking for antibodies against cyclic citrullonated peptides or CCP. And that is often part of either part of an assay or commonly drawn as well. That can kind of detect early stages of RA. And then another sort of inflammatory not precursor, but marker would be like C-reactive protein. And again, that's more so, it's an acute phase protein that typically is increased when there's acute inflammation. So, may or may not be helpful, but if you're suspecting some kind of inflammatory disease, they'll oftentimes get that as well.
Yeah.
But a host of labs on top of obviously symptoms and patient history and whatnot.
Right. So you mentioned we were going to compare and contrast osteoarthritis and rheumatoid arthritis. So I'll highlight some differences in really how they present and what to look out for. So these are just two types of arthritis, but people can have pain in joints for other reasons as well. The onset of osteoarthritis is usually insidious, which you can imagine because of the mechanism. That makes sense. So over many years, it's going to develop and kind of worsen. Rheumatoid arthritis can be gradual, but it can also be sudden. Sometimes it presents in just a matter of weeks or months. In terms of the stiffness and how long it lasts, osteoarthritis usually only lasts a few minutes. It's pretty localized, but short gelling effect after a prolonged rest. Rheumatoid arthritis, it can last at least an hour, often longer, and it's most pronounced after a rest. With the pain, osteoarthritis, you'll have pain on motion with prolonged activity, and it's relieved when you rest. Rheumatoid arthritis, you're going to have pain. You may have pain even at rest. A lot of times it can disturb people's sleep. I hear that from patients a lot. Mike mentioned the fatigue. You really don't get that with osteoarthritis, but you often have substantial fatigue with RA, like Mike said. Tenderness localized over the afflicted joint is common with osteoarthritis. It's also almost always present with RA. It's a very sensitive indicator of inflammation. Swelling, osteoarthritis, effusion is common. There's little synovial reaction. Swelling is rare. With RA, you have fusiform soft tissue enlargement. Effusion is also common. Synovial proliferation and thickening. Often it's symmetrical, like Mike said. Heat or erythema, it's unusual with osteoarthritis, but you sometimes see that with RA. And then joint enlargement. You may have mild joint enlargement with a firm consistency with osteo, but you may have moderate to severe joint enlargement with RA. You hear people complain about that with their finger joints and stuff like that.
Yeah, and like I mentioned earlier, the feet and hands tend to be like very common areas that these that RA starts to be bothersome. The wrists, elbows, knees are not. They're still somewhat common. They're just not as common as the hands and feet. And then things like the hips, certain areas of the like shoulders and whatnot would be, uncommon with RA, which is, with something like osteoarthritis, we see hip osteoarthritis is fairly common. So another kind of contrast there. But, another way of sort of diagnosing, or at least assisting with your overall diagnosis of RA is there's different scoring systems that can be done. One in particular is basically looking for certain markers, so like a low positive rheumatoid factor or ACPA, that's worth 2 points, for example. Here, a high positive RF or ACPA would be worth 3 points. If there's a high ESR or CRP, then that would be a point. If the duration of symptoms has been going on for 6 weeks or more, that's a point. And then looking at the joint involvement, and it has to be at least one joint that's not explained by another disease. But if it's 2 to 10 large joints, then you get an extra point. 1 to 3 small joints, plus or minus a large joint is 2 points, and it kind of just goes up from there to where you get to greater than 10 joints, and at least one of those has to be small. It's worth 5 points. But basically, when you add the patient's total score up, if it's 6 or more, that tends to be indicative of RA.
Right.
And there's several different disease activity scores and whatnot. There's like the clinical disease activity index. There's patient activity scale. There's simplified disease activity index. So there's several that are options that you could utilize, and it's going to be clinician specific and whatnot. It doesn't mean that one is necessarily the universally agreed upon assessment tool.
Right. Yeah, and they can help assess how well something is working, or sometimes it's difficult.
Severity.
It's difficult. Patients, when they're describing pain, and it's very subjective, it's difficult to determine if a patient is improving or not. They use the inflammatory markers to help with that as well. But you ready to talk about some medications?
Yeah, let's do it.
Let's do it.
Talk about the old school DMARDs first.
DMARDs.
So disease-modifying antirheumatic drugs, and this is basically the old school meds that do not encompass like the biologics, and we'll kind of get into those later. But these are definitely been around for a while, but very much still utilized in rheumatoid arthritis. And if patients are symptomatic, they should ideally be started on one of these DMARDs, and we'll talk about which ones are more prevalent than others, but they all kind of fall under that umbrella of that DMARD classification, but they all have their various mechanisms of action that work to slow the disease process and help prevent further joint damage. The treatment goal overall is hopefully get the patient into remission, or at least a low disease activity if they're starting off with really severe disease activity at baseline, then we may not be able to get them to complete remission, but at least making them much more comfortable and a better quality of life. One thing that I will make a note of is that steroids don't typically have a long-term place when it comes to rheumatoid arthritis. You may see like low-dose steroids being given sort of like as a bridge therapy while you're waiting for the actual DMARD, which is going to be like the maintenance med to take effect. And so like 10 milligrams of prednisone or less or an equivalent to that with another corticosteroid. You can do that for patients, typically more of the moderate to high disease activity when they're first starting a DMARD. But we want to ideally use the lowest effective dose that we can, because obviously we know the systemic side effects of corticosteroids can be problematic for sure, but also using it for the shortest amount of time it's possible. You may in some cases see NSAIDs being used, but they're definitely a weaker option for bridging, if you will, than something like a corticosteroid. But the big thing is just making sure that it's a limited thing, that you're not just keeping patients on prednisone indefinitely, to combat the symptoms. The DMARDs will combat the inflammation without a steroid after they've had time to take effect.
Right. Especially if they're in kind of like an active flare-up of symptoms. They might give them the low dose to bridge, or they might give them kind of a burst of steroids if it's like a substantial flare-up for a period of time. So methotrexate is a very common option used in rheumatoid arthritis, a very common DMARD. It's a folate antimetabolite. It inhibits DNA synthesis, repair, cellular replication, inhibits dihydrofolate reductase, which is how it has its effect. It's dosed 7.5 to 30 milligrams once weekly. It has an oral option. It also has a subcutaneous and intramuscular injectable options, but it's still once weekly either way. It does have a boxed warning for hepatotoxicity, myelosuppression, mucositis, which can be a very bothersome symptom. It shouldn't be used in pregnancy. It does have some other adverse effects that are a little more common: nausea, vomiting, diarrhea, type GI side effects. It can increase LFTs. It can cause hair loss, as well as photosensitivity. For monitoring, you want to check LFTs at baseline every 2 to 4 weeks for the first 3 months, which I don't often see done, but that is the recommendation. Or if they have a dose increase, they also suggest every 2 to 4 weeks for the first 3 months LFTs. Then every 8 to 12 weeks for 3 to 6 months, then you can kind of decrease the frequency. You do want to screen for hepatitis B and C before initiating methotrexate.
Yeah. And it's one of those things where I feel like overall, and with some of these hepatotoxic drugs, that we've gotten a little bit more relaxed. The longer they're used in clinical practice, people get more comfortable with not following strict monitoring parameters. Right. And it's something that's definitely fallen off the commonly used methods is something like a liver biopsy. And so nowadays, the only patients who would actually need a liver biopsy to test for any kind of like fibrosis or anything would be patients with like a history of excessive alcohol use. If they're having ongoing hepatitis B or C that it's not been treated or controlled, or patients that are having recurring elevation of aspartate aminotransferase over a period of time, then maybe we would go that route, but that would be few and far between when it comes to methotrexate nowadays. Patients, if they're having elevated LFTs, usually we can kind of just monitor via blood work, and we don't have to go that route. You see that with like Hep C and stuff now. There's lots of other tests and calculate, certain risk calculators and things as far as looking for advanced fibrosis or cirrhosis and whatnot.
Yep.
The other thing, like because of the mechanism of action, you can get a folate deficiency, or at least decreasing the amount of available folate in the body. And so, that can lead to certain hematological issues, GI issues, and hepatic adverse effects as well. And so oftentimes patients who are on methotrexate will be given a 5 milligram dose of folate orally, either weekly on the day following their methotrexate dose. Some patients will take a 1 milligram tablet once daily, on their non-methotrexate days. And keep in mind, the 1 milligram tablets are available as a prescription only. Like I think 0.8 milligrams is the highest dose available, usually in like prenatal vitamins over the counter. So making sure that even though a lot of insurance companies won't necessarily cover it, still write a prescription for the 1 milligram, and especially if the patient is going to do the 5 milligram once weekly dosing schedule.
Yep. Next DMARD, leflunomide. It inhibits pyrimidine synthesis, which causes or results in an anti-proliferative and anti-inflammatory effect. That's how it works. It also has a box warning for hepatotoxicity, as well as embryo-fetal toxicity. So methotrexate shouldn't be used in pregnancy. Leflunomide definitely shouldn't be used in pregnancy. And females must have a negative pregnancy test prior to and use 2 forms of birth control during treatment. If a patient wants to get pregnant, they have to wait 2 years after discontinuation unless undetectable levels are reached, or they need to use an accelerated drug elimination procedure, which we'll talk about in a second. It needs to be avoided in pre-existing liver disease. So if for example, if ALT is above 2 times the upper limit of normal, it would need to be avoided. And the LFTs need to be monitored monthly is the recommendation for the first 6 months of therapy.
Yeah, and there's some other warnings to keep in mind too. It does increase the risk of severe infections, certain hypersensitivity reactions like Stevens-Johnson syndrome. It can cause peripheral neuropathy. It also has been associated with hypertension. And then not as severe, but still somewhat common. GI issues, particularly nausea and diarrhea. It also can increase risk of respiratory infections, cause skin rash, headache, things like that. And we do typically want to get a TB screening before starting the medication, getting a CBC to look for signs of infection, and then LFTs and renal function would be ideal as well. And then Cole mentioned the accelerated drug elimination options or methods that are out there. And there's two main options that you can kind of go with. If the patient needs to get the drug out of their system, and despite its very long half-life of its active metabolite. So you could use cholestyramine, that bile acid sequestrant, and the dosing is 8 grams 3 times a day for 11 days to help eliminate the drug that way. Or you could also use activated charcoal suspension at 50 grams every 12 hours for 11 days. Those are both considered like accelerated drug elimination options. And again, if the patient just suddenly decides they want to become pregnant or what whatever the case may be, that they need to get rid of the drug out of their system, those options may need to be explored. Otherwise, it'll be a long wait.
Yeah, 2 years is a long time.
Sure is.
Next is sulfasalazine. It's a prodrug. It's cleaved by bacteria in the colon into sulfapyridine and 5-aminosalicylic acid. We assume the sulfapyridine moiety is responsible for the agent's antirheumatic properties, though the exact mechanism is not known. It is contraindicated with patients who have a sulfa or salicylate allergy. Also, if a patient has a GI or GU obstruction, you can't use it. Has some warnings associated with it. One for severe skin reactions like SJS, also hepatic failure and pulmonary fibrosis. But it has some more common adverse effects that you can see: headache, rash, weight loss, dyspepsia, GI upset, as well as folate deficiency. It has some similar monitoring. They recommend a CBC and LFTs at baseline, then every other week for 3 months, then monthly for 3 months, then once every 3 months. It can cause a yellow-orange coloration to the skin or the urine, so certainly a good thing to warn patients about.
Especially the orange part. Yellow, feel like yellow urine, we're all pretty used to that, but
eat some asparagus, you probably get
neon
that.
orange, it's a little could be a little concerning to some.
To some.
The another commonly used DMARD that's out there that was in the news quite a bit early on, like with COVID and whatnot, and is considered probably the more, lack of a better word, wimpier DMARD compared to the others we've talked about, but also can be effective for mild cases and doesn't have as many side effects and things associated with it, is hydroxychloroquine, Plaquenil. Its mechanism of action is it's inhibiting the locomotion of neutrophils and chemotaxis of eosinophils, so it impairs complement-dependent antigen-antibody reactions as well. Some warnings that are associated with hydroxychloroquine would be the potential for irreversible retinopathy, macular pigment changes, neuromuscular weakness, cardiomyopathy, bone marrow suppression, anemia, leukopenia, thrombocytopenia, whatnot. And then again, with the more common side effects that aren't as severe, the GI issues, nausea, vomiting, diarrhea, abdominal pain, rash, pigmentation, changes of the skin and hair, which is going to be a lot more rare than the others mentioned, but, and not life-threatening, but obviously cosmetically may bother the patient. So just to give them a heads up about that. And then monitoring, typically we're getting a CBC LFTs at baseline and then periodically, although it's not as specific as some of the others that we've already talked about. Now, as far as the retinal damage that potentially can be irreversible, we do have certain criteria where we would, get a eye exam, ophthalmologic exam, in patients who have certain risk factors, especially if they're at risk for developing retinal damage at baseline. So patients that have low body weight, if patients have renal or hepatic impairment at baseline, then the eye exam should be conducted annually while they're on treatment. If patients don't have risk factors for developing retinal damage, then the eye exam should be completed within 5 years of starting hydroxychloroquine, and then after that is repeated annually. But they get a little bit more time at the beginning to, where they don't necessarily have to get an eye exam right away. But making sure that patients do actually follow up and have that done is important.
As far as where it's used, it's often used in mild RA or as an adjuvant in combination with other DMARD therapy in more progressive disease for kind of the same reason Mike mentioned, it being a little bit wimpy. The onset of action may be delayed up to 6 weeks, and it's not totally unusual with some of these drugs. They don't typically work overnight except for the steroids. It's considered a therapeutic failure only when 6 months of therapy has gone by without a response, and the main advantage of it is the lack of myelosuppression, hepatic and renal toxicities that may be seen with other DMARDs. So it has the eye issues, obviously, but doesn't have some of these other toxicities that the others are associated with.
Yeah. So of the 4 DMARDs that we've already discussed, by far the most prevalent and usually considered to be the preferred option is methotrexate.
Yep.
And then based on patient comorbidities and other risk factors and stuff, you may opt to go with a different option. Or if methotrexate wasn't a success or couldn't be tolerated, then one option could be to look at an alternative DMARD. And then, like Cole said, in mild cases, hydroxychloroquine may be the better option because you don't have to worry about the more serious side effects.
Right.
So, those 4 are the most commonly seen options, and definitely methotrexate, though, is usually considered first line.
Yep.
So before we jump into the biologics, let's do the password for the post-activity.
Great idea.
Post-activity exam, whatever you call it. I always want to say quiz or exam, and I can never decide which one.
I think normally you say test. Don't you say test?
Do I?
Post-activity test. That's what you usually say.
I always get to that point in my head as I'm saying it out loud, and I'm just like, oh no, what's going to come out of my mouth today? I need to just pick one and stick with it.
The post-activity evaluation. That's something different, actually. Never mind.
Nah, that's a good one. Maybe. Yeah. But then, whatever. Doesn't matter. Whatever the heck it's called. Password is going to be RA25. So making sure that, again, for all of you who are members with, have unlimited memberships to Free CE's platform, go to their website. Under the Learn tab, you can see the different, monographs, live lectures, and then podcast will be its own separate category. And then on just make sure you pick this episode out of all the ones that are listed on their website and put that in there and take your 10-question quiz, exam, evaluation, whatever the heck it is, and crush that. Get your 1 hour of continuing education credit. Make sure you get ready for those those license renewals whenever that may be time in your state.
That's right.
Yep.
Okay.
Ours is coming up.
Yes,
we mentioned that last time too.
Yes, it is.
So guess
too soon.
Yeah.
Jump
into these biologics.
Yeah, we'll talk about the biologics. We'll start with the TNF alpha blockers. First being the most common one, which is Humira, adalimumab. It is less antigenic than infliximab, another one we'll talk about. It's administered subcutaneously, standardly every 14 days for rheumatoid arthritis. There are situations where it's done once weekly for other reasons. Local injection site reactions were the most common adverse reactions noted in clinical trials. It had similar response rates to those seen with other TNF inhibitors. There's a host of biosimilars available now. You'll probably see a lot of, mid last year, we started to see a lot of insurances prompt patients to switch. Beginning of this year, even more insurances. So you'll start seeing them more often. Examples are Soltezo, Amgevita, but there's a bunch of them.
Yeah, there's a ton available now. It's kind of crazy.
Yeah.
And you'll also see I personally refer to these as like the TNF alpha biologics, but you'll see these referred to also as like biological DMARDs. And usually when we're talking about biologics, they kind of subcategorize them into either anti-TNF alpha biologics or non-anti-TNF alpha biologics, because the non-TNF alphas are various mechanisms of action, so they just get their own separate category. So the ones we're talking about now are all the TNF alpha, biologic DMARDs, if you will.
Right.
The next one we'll talk about is probably, in most cases, the weaker option out of all of the TNF alphas, and it's Enbrel. It's usually given subcutaneously weekly. Again, adverse effects commonly causes localized injection site reactions and pain. In some cases, it can be obviously a much more rare situation, but it can cause neurologic demyelinating syndromes, like even it's thought to be associated with like multiple sclerosis and things like that. Very rare, but still something to be aware of based on patients' actual history or family history. And when it comes to clinical trials and its effectiveness, it has been shown to slow disease progression to a greater degree than something like oral methotrexate, which is kind of the case for all these biologics. It also has a host of biosimilars available, and it's like Cole said, just making sure you're following up with the patient's formularies, whatever insurance plan they have, to make sure that you know which one needs to be written for, because some are interchangeable and some are not.
Right.
So, that can definitely hold up therapy if not done properly.
Right. So you might need a new prescription many times. It's good for the provider to be aware either way. There are subtle differences with the injector devices. Usually it's like, does it have a button, does it not have a button? But for the most part, everything is pretty similar between them. Okay. So infliximab, Remicade, is another anti-TNF biologic. It's IV at a dose of 3 milligrams per kilogram at 0, 2, and 6 weeks, and then every 8 weeks after that. To prevent the formation of antibody response to the foreign protein, oral methotrexate should be given concurrently for as long as the patient continues on infliximab. So these are going to be used together. Loss of response may be seen in patients with RA who have a good initial response, requiring increased doses or shorter intervals between doses to maintain the response. Acute infusion reactions with symptoms like fever, chills, itching, rash may occur during the infusion or within 1 to 2 hours after giving the drug. Treatment includes slowing infusion rates, administering Tylenol, Benadryl, or steroids, depending on how severe the symptoms are. It also has various biosimilars available. For example, Inflectra, Renvelsis. So another one with biosimilars.
Yeah. And then there's a couple others like Simponi, golimumab, which is another sub-Q as well as IV. There's the Simponi Aria, which is the IV formulation. And then there is Cimzia, which is certolizumab, is available as a sub-Q injection as well. And again, those are both TNF alpha inhibitors. They have, varying degrees of efficacy, but I don't know. Which, in my experience, I feel like the infliximab and adalimumab are the two most commonly used TNF alpha inhibitors. Are you kind of seeing the same thing, or?
Definitely Humira. I suppose I do see infliximab a fair amount. I feel like I see Enbrel more often, and then I'll see Cimzia pop up in like a pregnancy situation.
Gotcha.
But yes, definitely infliximab is also used.
And there's some overall things to consider with this class, as a whole. They do carry a box warning for the increased risk of serious infections, some of which could potentially even be fatal. Also increases the risk of developing lymphomas or other malignancies. So, definitely a serious box warning to make sure the patient is kind of aware of, and you're doing proper monitoring. Some other warnings that are associated with this class of meds: potential for causing demyelinating diseases, lowering the seizure threshold, causing hepatitis B reactivation, causing issues in patients with heart failure. They can be hepatotoxic in some cases, especially with underlying Hep B or some type of infection like that. We typically you may see these used with regular old school DMARDs like methotrexate. And in fact, that's fairly common. And a lot of patients do continue methotrexate when they are started on a TNF alpha biologic, but we're not using them with other biologic DMARDs. So the non-TNF alpha biologics, we don't combine those together. And also would not want to give live vaccines while they're on therapy.
Right.
At baseline, we typically would get a TB test. We would test the patient for hepatitis B and looking for hepatitis B surface antigen as well as the core antibody. And you could look at a surface antibody too to see if they're immunized against hepatitis B. And if not, then maybe consider doing that. Getting a CBC, checking their LFTs, and all that should be done prior to starting and then during treatment periodically, at the clinician's discretion. Like I said, oftentimes given along with methotrexate, and in some cases where the patient at baseline, has a very severe disease activity, methotrexate along with one of these TNF alpha biologics may be the route to go.
Yep. Okay. So moving on to the non-TNF biologics. First one we'll talk about is Orencia, a beta-sept. It inhibits T cell activation by binding to CD80 and CD86 on antigen-presenting cells. It blocks the required CD28 interaction between antigen-presenting cells and T cells. It has a boxed warning for serious infections as well. TB needs to be screened for before starting. Also has a boxed warning for increased risk for malignancies. In patients who failed to achieve an adequate response with a TNF alpha inhibitor, one half had a clinical response to Orencia. So there's data to support benefit after a TNF alpha inhibitor was failed. There was a trial called the AMPLE trial. It was a head-to-head trial looking at Orencia added to a stable methotrexate dose, which showed similar efficacy and adverse effects to Humira plus methotrexate in biologic-naive patients with an inadequate response to methotrexate by itself. So basically saying Orencia plus methotrexate similar to Humira plus methotrexate.
Yeah.
Has some adverse effects associated with it: headache, nausea, infections, nasopharyngitis, injection site reactions, as well as antibody development. And you want to use caution in patients who have COPD. There's an increased risk for worsened symptoms.
Another non-TNF alpha biologic option would be rituximab, which works by depleting CD20 B cells that are believed to have a role in RA development and progression. Similar box warning as the previously mentioned med, so serious issues when it comes to like hepatitis B reactivation. And so there's actually been cases of like hepatic failure because of this. So again, screening for hep B and even hep C prior to treatment. There's also been associated to serious and even fatal infusion related reactions, which is also a box warning on this one. And then there's also case reports of PML, due to a CJ virus infection, and so screening for that when indicated. It's also useful based on some of the studies that are out there, useful in patients who have failed methotrexate or patients who have failed a trial of a TNF alpha inhibitor, and switching over to rituximab can still be effective in those patients. So, that can be one strategy if they've already kind of started with some of the first line agents already. And it's got kind of a unique dosing schedule. So it's an infusion that's given 2 weeks apart, and it's just two separate infusions. And then you kind of have a prolonged period where you would wait, and doesn't mean that it's a one and done thing. Some patients may need to be retreated if their disease reactivates, but it's not clear as far as like how long you need to wait or the ideal time.
Right.
And then as far as the getting the actual infusion, there can be a pretty high dose of steroid that goes along with that. So something like methylprednisolone, like 100 milligrams, could be given 30 minutes prior to the rituximab, and obviously that it reduces the incidence and severity of those infusion reactions. So that's definitely a concern, and when administering this particular med. Methotrexate ideally would be given concurrently in the usual doses, and that combination has been proven to be effective and provide the best therapeutic outcomes, assuming that they can tolerate or don't have a contraindication to methotrexate. And some other adverse effects that aren't as severe, but definitely can be concerning. It's been associated with hypertension, weight gain, peripheral edema, insomnia, upper respiratory tract infections, UTIs, GI upset, and so definitely not a benign medication either. But again, an option for patients who have kind of gone through some of the more commonly first line agents and have not gotten to remission.
Yep. Next med is Actemra, tocilizumab. Its mechanism, it attaches to IL-6 receptors, preventing the cytokines from interacting with the IL-6 receptors. It has box warnings for serious TB infection as well, so it needs to be screened for beforehand. Warnings for increased LFTs, neutropenia, thrombocytopenia, lipid abnormalities as well. So you'll kind of see the lipid piece pop in with some of these drugs. So where that's relevant, just make sure that's monitored for. It's approved for use in adults with moderate to severe active RA who failed to respond to one or more other DMARD. One study referencing it is the ADACTA trial, where patients with severe RA unable to use methotrexate found Actemra monotherapy more efficacious in symptom improvement than Humira monotherapy. Has some adverse effects, increased risk for upper respiratory infections, potentially hypertension, infusion site reactions. We mentioned the increased LDL and total cholesterol that would need to be monitored for.
So yeah, and that all, like I said, all of those are kind of encompassed under the non-TNF alpha biologic category. And then we also have a third category as well, which is a lot of times saved for, I guess you'd say, last line, although not technically, but usually the patient's trialed TNF alpha inhibitor or non-TNF alpha inhibitor before going this route. But we have the Janus kinase inhibitors are also available. So the first one to market, Xeljanz, tofacitinib, is it's probably it's still commonly used, even though it was the first to market. It inhibits that JAK enzyme, which is responsible for stimulating immune cell function. It has several different box warnings associated with it now, including serious infection risk, which could be fungal, viral, bacterial, also potentially an increased risk of lymphomas. And when we get done talking about this class, we'll talk about some of the newer warnings that are now associated with this class as well. But this drug in particular has also been associated with increased LFTs, hasn't been studied thoroughly in patients that have a creatinine clearance less than 40. Still want to avoid live vaccines if the patient's currently taking this med. And, common adverse effects, definitely upper respiratory tract infections, urinary tract infections, GI issues, particularly diarrhea, headache, hypertension, increased lipids, all can definitely pop up and definitely be something that should be monitored for if the patient's on this therapy.
Right. I think you already mentioned, did you mention the dosing as well?
No.
Okay. So you mentioned monitoring CBC lipids baseline every 4 to 8 weeks. Or 48 weeks later, then every 3 months after that. LFTs, they do recommend a baseline and then periodically. They note that patients of Asian descent have an increased frequency of adverse effects. Its dosing can be 5 milligrams twice a day. It's also available as a 11 milligram extended release once daily tablet. When switching from 5 milligram XR to 5 milligrams to XR, start the XR the day following the last dose of 5 milligrams. It does have some drug interactions, so don't use it with strong CYP3A4 inducers. Only give 5 milligrams once daily if taking with a moderate CYP3A4 inhibitor or a strong CYP2C19 inhibitors. So, this one's pricey like many of the others. And it does have, Mike mentioned the creatinine clearance. I believe if it's less than 60, then they're supposed to be on the 5 milligrams twice a day, for example. So just be aware of that.
And then another option in this class is baricitinib. It's a Janus kinase 1 and 2 inhibitor. It was approved back in 2018, and again indicated for moderate to severe active rheumatoid arthritis in patients who have had an inadequate response to at least one TNF alpha inhibitor, and oftentimes they've trialed a non-TNF alpha inhibitor as well before getting on this, but it can be used either alone or in combination with methotrexate or another one of the original DMARDs, non-biologic DMARDs, and should not be used with other biologics and potent immunosuppressive agents like azathioprine, cyclosporin, things like that.
Another one is Rinvoq, upadacitinib. This one's been approved for over 5 years now. It's a 15 milligram capsule taken once a day. It does not have any recommended renal dose adjustments, but it wasn't studied in eGFR less than 15 milliliters per minute. In the Select Beyond trial, Rinvoq plus methotrexate was compared to Humira plus methotrexate. Rinvoq was superior in improving signs, symptoms, and physical function. Rinvoq had higher rates of herpes zoster and creatinine phosphokinase elevations.
And like we mentioned, a lot of times these are kind of saved more for one of the more towards the end of the algorithm, if you will. There's some reasons why we wouldn't start these. For in particular, if the patient has an absolute lymphocyte count of less than 500, then we typically wouldn't start one of these options. If their hemoglobin is less than 8 at baseline, or if their ANC is less than 1,000. Also, warning patients about the risk of malignancy. There's also of note an increased risk of thrombosis that's been identified as well, and then increased risk of death. Specifically, tofacitinib is in patients that are 50 years of age and older with one or more cardiovascular risk factor. There was a special alert put out by the FDA in September of 2021, and showing that due to the excessive risks that we kind of mentioned above, patients should ideally have tried and failed at least one TNF alpha inhibitor prior to using any of the Janus kinase inhibitors. And like as I mentioned, in the algorithm, they typically will recommend one of the non-TNF alpha biologics as well before moving to this route.
Right.
All right. Let's talk about some other considerations when we're talking about all these different treatment options.
Yeah, let's do it.
Yeah, go ahead. Sorry.
Okay. So there's a couple of studies to mention related to triple therapy and double therapy with various DMARDs and biologic agents. One is the CSP-551 RACAT trial. Sounds like a Pokemon.
It does.
It compared triple therapy with methotrexate, sulfasalazine, and hydrochloroquine with Enbrel plus methotrexate, and it saw non-inferior clinical benefit. So basically saying Enbrel plus methotrexate was non-inferior to these other three DMARDs together. There's also the SWIFOT trial, which compared the same triple therapy, methotrexate, sulfasalazine, hydrochloroquine, with infliximab and methotrexate. Infliximab and methotrexate had more benefit at 12 months, and then at the 24-month follow-up, non-inferior, no difference in clinical benefit. Indirect comparisons of randomized trial results in a 2011 meta-analysis suggested that patients receiving Humira or Simponi had statistically significantly lower rates of withdrawal from trials due to adverse effects compared with infliximab. Increased risk of serious infection associated with infliximab, adalimumab, certolizumab, but not Enbrel or Simponi, compared to placebo or traditional DMARDs in patients with rheumatoid arthritis was shown in one study in 2014 as well.
Yeah, and I think especially those first two that you mentioned, I think that's important because, like you said, all of these biologics, the Janus kinase inhibitors, I mean, the price tag associated with them is definitely not cheap. And so, for patients who are uninsured or don't have access to patient assistance programs or what have you, there's evidence that shows that we can make some of these old school meds that are fairly inexpensive, still work a lot of
Right.
the time, even compared to our more expensive newer stuff. But
Right.
there are also a lot of different patient assistance programs out there, 340B pharmacies at like FQHCs and other entities like that. Definitely have some of these that are affordable. I know if KHC I work with, the Humira is definitely much more affordable than if you were just to go to like a retail pharmacy.
Right.
So there's definitely ways of getting patients these meds as well. But when push comes to shove, if the financial piece is the biggest burden, we can make some of these old school meds work still.
Right. Okay. So in patients with moderate or high disease activity, despite DMARD monotherapy, this is kind of getting into what you can use and when to use it. You can use any of these options, each with or without methotrexate, instead of continuing DMARD therapy. So you can do DMARD combination therapy, either double or triple. You can have the addition of TNF inhibitors, non-TNF biologics, or tofacitinib following biologic DMARDs with methotrexate, if possible. This would be moderate or high disease activity.
And patients, again, moderate to high disease activity who have been on a single TNF alpha inhibitor, especially if it was monotherapy, considering adding 1 or 2 DMARDs if they're currently not taking a regular DMARD like methotrexate. If they're on Humira, for example, by itself, adding methotrexate to that can definitely kind of boost its efficacy. We also could consider switching to a non-TNF alpha biologic, and the College of Rheumatology does recommend that strategy over switching to the JAK inhibitors or another TNF alpha inhibitor, although it's not technically wrong to go that route. It just seems to be preferred to do a non-TNF alpha biologic at that point.
Right.
And then patients who have a moderate to high disease activity, even if they've been on 2 or more sequential TNF alpha inhibitor trials, then consider, if you are making a switch again, switching to a non-TNF alpha biologic over one of the JAK inhibitors, and then also over a third TNF alpha inhibitor. So there are cases where maybe infliximab was working and then didn't work after a while, and they got switched to Humira, and maybe that's not as effective as we were hoping. At that point, switching to one of the non-TNF alpha biologics would be the preferred route to go.
Right. In patients with moderate or high disease activity, despite at least 1 TNF inhibitor and 1 non-TNF biologic sequentially, not together, consider another non-TNF biologic with or without methotrexate as the first option over a JAK inhibitor, and then a JAK inhibitor after the second non-TNF biologic. In patients in remission, typically you don't discontinue all their therapies. Very frequently, it's just going to end up recurring, but you can consider tapering therapy to the lowest effective dose, or consider coming off of it. But a lot of times it ends up recurring.
Yeah. So to kind of recap all that, if we have a patient, if they're DMARD naive, we're starting them on one of the traditional DMARDs. Usually methotrexate's preferred, with or without prednisone for a short period of time to kind of bridge therapy until the methotrexate has time to kick in. If they do have moderate to high disease activity at baseline, we may end up adding a biologic right from the start. It doesn't have to be a TNF alpha inhibitor, although I feel like that's a lot of times the route that they kind of go, unless there's a contraindication or some reason why we couldn't use a TNF alpha inhibitor. But that combination of like methotrexate with TNF alpha inhibitor is usually the starting point when you get into the biologic space. And then from there, if you've had a single TNF alpha failure, the ideal route would be switching to a non-TNF alpha biologic. You could also consider a second TNF alpha with or without methotrexate, but ideally non-TNF alpha biologic. And then from there, a second non-TNF alpha biologic, and then a JAK inhibitor. If the patient starts off with a non-TNF alpha biologic, then we would ideally go to a second non-TNF alpha biologic, and then consider a TNF alpha inhibitor after that if they're treatment naive or a JAK inhibitor. You can kind of pick your poison at that point. But the big thing is kind of not being repetitive with the TNF alpha inhibitors and utilizing a non-TNF alpha biologic that has a different mechanism, than was used previously.
Right.
Which I feel like the terminology there, I wish there was a better way of kind of distinguishing, because I feel like that can get really confusing. But yeah, working with these all the time, you're going to be familiar with mechanisms and what's what.
Right. There are a few comorbidities to be aware of, and kind of what to do in these situations. If a patient has latent or active tuberculosis, most often in real life you're going to see the biologics held until that's worked up or dealt with. If something needs to be used, for example, with tofacitinib, you would want to wait after 1 month. You would want to wait at least a month after treatment for latent TB, and you wouldn't want to use it until after the completion of treatment for active TB. If a patient is pregnant or breastfeeding, like we mentioned earlier, avoid methotrexate or leflunomab. If a patient has heart failure, the preference would be a non-TNF inhibitor therapy. If a patient has skin cancer, use DMARDs, preferably over biologics or a JAK inhibitor. Previously treated lymphoproliferative disorder, you would use rituximab. There's no restrictions for Hep C infection, but if a patient has untreated chronic Hep B, for example, or hepatitis B infection, or if they have chronic Hep B, you wouldn't use biologics. If they previously had Hep B that's been treated or they're receiving treatment, then there's no restrictions. Or if they have previous serious infections, use combination DMARD therapy or abatacept over a TNF inhibitor.
Yep. So there you go. There it is. I think we're right at an hour. But definitely a lot to consider when it comes to comorbidities, total patient picture versus just arbitrarily picking one of these meds, and then also taking into account insurance coverage and all that good stuff as well. So a lot that goes into these, which is oftentimes why they're handled by specialty pharmacies and specialists that are prescribing them. But definitely in certain settings, even in like internal medicine or family medicine, you may still run into these.
Right.
And definitely important to be familiar with them nonetheless.
That's right.
But anything else that we need to make sure we discuss for RA?
Not for RA. That's all I got.
Or at least not for tonight. Cause
not for tonight.
We could probably, how long could we actually spend on RA if we wanted to? It'd be crazy. But we would have to, kind of let much more experienced people come in for that role.
Sure.
But definitely make sure you check out FreeC's website if you are not a member already. Thanks to them for continuing to work with us. And if you want more structured, lecture style content and PowerPoint slides and all that good stuff, then check out our Patreon. It's patreon.com/coreconsultrx. And if you sign up for an annual membership, you will get a copy of the Landmark Clinical Trials book by Dr. Alex Poppin, which has like over 175 different summaries of landmark trials and is a great resource. You get a free digital copy of that if you sign up with an annual membership. And so thanks to him for working with us and kind of being a friend and sponsor of the podcast for a while. Make sure you check out Drug Info app Pearls, pyrls.com/coreconsultrx. They have lots of great content. If you heard our diabetes episode from 2 weeks ago, he's got a whole new update on his platform now for Pearls that has the newest 2025 ADA algorithm and all that good stuff, plus a list of all those changes and things that were added to the guidelines, or the verbiage that was changed in the guidelines this time around. So a great resource and constantly adding new content. So definitely check them out as well. And Cole, you want to tell the people about your drug info searching tool?
Yep. MedSearch Chrome extension on the Chrome Web Store helps you search all your medical websites with just 1 or 2 clicks. Speeds up your day a little bit. Check it out.
2 clicks or your money back.
Yes. I will give you your money back. Just ask me.
All right, guys. Thank you so much for listening. We'll see you guys in the next episode. Have a good one.